My learning objectives are quite a few, but really over all of it, I hope that there's something practicable that you can take back to your practice from today's learning. But we want to look closely at antibiotic resistance, the history of it, the future predicted state of antimicrobial resistance, look at some of those mechanisms that cause resistance within the structure of our organisms, and really be able to describe the impact of contaminated blood cultures on patients, antimicrobial stewardship efforts, and then, of course, the quality outcomes that follow that. We'll look in detail at some evidence-based practices for blood culture collection and illustrate the limitations of how blood culture collection that is just our standard practice is minimized in being able to get us our outcomes that we really desire for our patients. And we'll look at the critical role that the clinicians have in that practice and identify some tools for you. Please do post any questions that you have in the chat. And Kelsey, I'm hoping that you will act. We have some polling questions in here. And the first one, really what I'd love to know is your role within the department that you represent today. Is it infection prevention, quality and safety, staff nursing, pharmacy, ASM, clinical lab, or other? If you wouldn't mind letting me know, that gives me a good idea. I'm assuming most of you are in infection prevention. But we found that these attract other people as well, so belonging to APIC. And then Kelsey, if you can let me know where the majority are from the chat, that would be awesome.
Absolutely. So far, we've gotten all A's. Lots and lots of responses, but all A's. Oh, and awesome. A couple B's coming in as well.
Okay, fantastic. Thank you for sharing that, and thank you again for being here. We wanted to look just a quick review of antimicrobial resistance. When we look at the first person in the world saved by antibiotics, it was Mrs. Ann Miller of New Haven, Connecticut. She was truly near death. She was going in and out of consciousness, and her doctors had done everything for her. They'd given her sulfa drugs, they'd done surgeries, they'd given her transfusions, and everything was failing. She was dying, and as she was going in and out of consciousness, her doctors got a hold of a tiny amount of a highly experimental drug called penicillin, and they gave her one injection of it. And in her record, which is now in the Smithsonian, it reads that the very next morning, Mrs. Ann Miller was sitting up in bed, eating breakfast, completely lucid. And that was the power of one injection of penicillin in its heyday, right, in the first part. So you can imagine now what we are with penicillin today. And even in 1945, when Dr. Fleming received the Nobel Prize for penicillin, he warned that this high public demand would create an era of abuse. And he was right. By 1960, way back then, the year of my birth, yes, I'm older than Dirk, above 80% of both our community and hospital-acquired staph isolates had already shown resistance to penicillin. So with that, we wanted to look at, so what are the causes of antibiotic-resistant bacteria? And this is it. The antibiotic resistance has several routes that it can take, right? Both in hospital, which we're very, very aware of that pathway, but what we kind of don't see and hear so much about is the pathway within agriculture. But I want you to see what's highlighted here. In 2013, globally, we used 131,000 tons of antibiotics in agriculture. And it typically isn't given to make a sick animal well, it's given to make them grow quickly and grow fat quickly. And with that, then our agriculture develops resistance. And if we don't wash our fruits and vegetables well, where we've used their fertilizer, or we undercook our meat, we can actually acquire resistant organisms from animals. And the thing is that there's just such an incredible amount of acquisition of resistant organisms during this, and we don't realize the whole agricultural pathway. You're very familiar with the pathway within healthcare, so we don't need to go over that, but this was stunning information to me. And so what are antibiotic resistant? As you know, those organisms that only one antibiotic can kill, 90% of them can only be killed with only one last resort antibiotic. And the problem with that is those antibiotics are much more toxic to our patients and much more expensive. Our common organisms that we see that are resistant, just want to talk about one of them, Clostridium difficile. We understand that we still lose 15,000 patients each year in the United States within the first 30 days of onset of C. diff. And that is something that we have a direct responsibility for, because the #1 cause of C. diff is utilization of antibiotics, and we never ever want them to be unnecessarily utilized. And bacteria are incredibly ingenious organisms. They have all of these different mechanisms within their structure to be able to resist antibiotics. One is the efflux pumps, right? It actually surrounds the antibiotic within the organism and just pukes it back out of the cell. I don't know a nicer term to say use than that, but it just pumps it back out of the cell. Another one is just inactivation of the drug, or when we use antibiotics, we target certain structures within the cell of the organism, and they can actually modify that structure so that it inactivates the effectiveness of the antibiotic. The final and my favorite, a personal favorite, is limiting uptake of that drug by laying down this massive lipid layer around their outside. This year when I went to the doctor and he told me I was 15 pounds overweight and I was pre-diabetic and I needed to do something about it, I told him it was just a defense mechanism like bacteria. I was laying an extra lipid layer down around my outer shell. He did not find it funny. So anyway, the criticality of antibiotics, as you know, is that we haven't had a new class of antibiotics since the 1980s, which was daptomycin. And our dependence for our patients on them is critical. You can see the numbers here. But when we look to organ transplant, 33,000 organ transplants were completed in 2016 in the US. We have over 500,000 people in chemotherapy. Our renal patients, over 500,000. Chronically ill with diabetes, 30 million. And you know the utilization of antibiotics is frequent in these patients, and so we are critically dependent upon them. Last year in the Lancet, they had done research as of 2019 about the burden, the global burden of antimicrobial resistance. And what they found is that we had almost 5 million deaths associated with drug-resistant bacterial infections as of 2019. 1.3 million of those deaths were directly caused by antimicrobial resistance. So they took out all the outliers, they took out all the comorbidities, and they said, no, just 1.3 million just due only to antimicrobial resistance. So we are at a crisis, and I want you to see this graph here, and what it shows, and it's a lot of small print, so I don't really expect you to be able to read it, but what it shows is the inequity of resistance. What we have is much higher rates of resistance in low-income countries and geographies. And so that's something truly that we can help make equitable, more healthcare more equitable as well as we become better stewards of antibiotics. Dr. Srinivasan from the CDC told us that by 2050, we expect 10 million people dying annually to antibiotic-resistant infections if they're not changes, right? And that then makes antibiotic resistance the leading cause of death ahead of cancer. And that fundamentally challenges the very future of medicine, right? We know the problem is bad now, but the projections of what is going to happen if we don't do something are terrifying. And then, of course, there's the cost of resistance, a total of $50 billion, a whopping cost, $35 billion in loss of productivity and $20 billion for healthcare for those patients. And I do want to share a story with you that I heard when I was speaking at the Presidential Advisory Council on Combating Antibiotic Resistant Bacteria. We were very honored that day to have 4 patient representatives tell us their story of dealing with resistant organisms. The last person that spoke that day was a father there representing his son. His son was in the military and got an injury on his finger. His finger had to be amputated. And then he got a skin and soft tissue infection. And so we treated him with Vanco. That's what we used for that. And we thought the infection was gone, and it wasn't. So we got more Vanco. And this story repeated itself until he developed vancomycin resistance. The toxicity from those organisms damaged his heart to the point where he had to go to Stanford Medical Center in Northern California and have open heart surgery to correct the damage. He did. Everything went very well. He was being discharged from Stanford. His dad picked him up. They were coming home to their home state of Nevada. He'd been in the car about 4 hours, and his dad said he started to shake. And he thought, I can't believe you already are acting like you've got another infection. You've had 4 hours free of antibiotics in your system. But he continued to get worse, and so they drove him to a hospital in their home state of Nevada. They admitted him. They gave him more antibiotics. And his son went through that course of antibiotics, and he was being discharged, and his dad came to pick him up And he said, just before we go, Dad, I'm going to use the restroom. He walked into the restroom and his dad said it was just too quiet. He called out to his son. There was no answer. He knocked on the door, nothing. He pushed the door open and he found his son unconscious on the bathroom floor. He checked for a pulse. There was none. He screamed for help. And he said the terror that went through him, realizing that he was going to have to do chest compressions on his fresh chest injury, where his son had just gotten all of his heart issues fixed, and he was going to have to do chest compressions, absolutely blew his mind, but he started chest compressions anyway. Medical personnel came in and relieved him, continued CPR, and his son died that day. He said he went out into the hallway and lied to his wife to get her to the hospital safely. And there in the hallway, he told his wife that their son was dead. He said the sound that came from her voice should never be heard by any human. And I share that story with you because I think it's easier for us to look at the stats of antimicrobial resistance and realize the lives lost than to hear one story of one life lost. But I hope as you continue your fight for antimicrobial stewardship, that you will remember the life lost and that you will rally for antimicrobial stewardship because we know how much it costs each family. So I have a question for you, and Kelsey, again, if you'll just let me know what the answers are, what the averages are, that'd be awesome. But the global burden of antimicrobial drug resistance as of 2019 was 8 million deaths, with 2.3 directly caused by AMR, or 5 million deaths associated with drug-resistant bacterial infections, with 1.3 million deaths directly caused by AMR. Oh, sorry, I don't know what I did or how that happened, but we'll get back there. Or 3 million deaths associated with drug-resistant bacterial infections. Any consensus on the answers?
We're seeing a lot of B's in chat, Tammy. There are a couple C's, but B,
Awesome.
I think, is our consensus.
Well, you guys are great and awesome and listening so well to me ramble on, so thank you. CDC tells us that there's only 4 ways, right, to stop antimicrobial resistance. And the first one is to prevent an infection from happening in the first place. This is your whole career pathway, so thank you for what you do. But obviously, we never want to be causing an infectious process, as in C. diff, right? And the main cause of that is antibiotics. And so then antimicrobial stewardship is paramount for us, right? We only want to give what's necessary and appropriate. And then working to prevent its spread. We don't want patients in the hospital one moment longer than they need to be there, because we know we carry resistant organisms within our acute care facilities, and we don't want to expose patients to those unnecessarily. So out of those 4 ways, just if we had diagnostic stewardship, that can help achieve 3 of the 4 ways to stop resistance. So we're going to turn now and pivot a little bit and look at diagnostic safety and stewardship that leads to antimicrobial stewardship and quality outcomes. Specifically, as we're drawing a blood culture in the pre-analytic phase, what we do while we're drawing that blood culture is incredibly important and will help drive antimicrobial stewardship and quality outcomes for our patients. But I love this quote by CDC. They said, diagnostics can be just as critical for fighting infections as antibiotics. And I have to apologize to you. Every once in a while, my tongue wants to play whack-a-mole in my mouth. So if I do, just bear with me. But HRQ did a really interesting report on diagnostic accuracy and error in the ED. And that final report listed that sepsis was number 6 out of the top 10 diagnostic errors in the ED. And so we do have a long way to go in being able to get our diagnostics right for our patients so that we can treat appropriately and have the quality outcomes that we desire. And now we'll turn to diagnostic stewardship and blood culture accuracy. And we all know that the purpose of blood cultures is obviously to confirm the presence of microorganisms in the bloodstream. We never want to pick up what's on the skin, get it into the bottle, and then confound everybody's decision-making process. Want to be able to identify the etiology of that organism and then let that help us determine the source of the infection and provide the appropriate antibiotic. When we look at blood culture definitions and contamination definitions, It's defined in CLSI and many pieces of literature. A blood culture contamination is defined as the recovery of normal skin flora in the adult, we're talking about normal skin flora from a single blood culture when we've taken multiple sets of blood cultures, right? We have to always take at least 2 sets in the adult to know, is this a contamination or is it a true bacteremia fungemia? And then culture is defined as a specimen of blood that's submitted for bacterial or fungal culture, irrespective of the number of bottles or tubes into which the specimen is divided. So what it's saying is we can't poke the patient once, fill 4 bottles on the adult, and then call it 2 sets. That doesn't fly because we can cross-transfer organisms to all 4 bottles or at least 2 of the bottles in one of the sets. And then we think we're looking at a true bacteremia when we're not. So very important that we always have 2 sites with 2 sets. And then a blood culture contamination rate obviously represents the common commensal organism occurrence in that set of blood cultures. And the blood culture set then is typically an aerobic and anaerobic bottle into which a single specimen of blood is divided again. We talk about required volume being essential and assumed. I like to call it the Goldilocks principle because it helps you remember that it's not too little, it's not too much. We have errors on both sides of blood culture collection. If we have too little blood and too much blood, we need just the right amount according to that bottle manufacturer's instructions. Typically, it's 8 to 10 milliliters per bottle on our adult blood cultures. When we get too little, we can actually miss the organisms that we're trying to find. If we get 40 milliliters to the microbiology laboratory, they have about an 89% chance of capturing those organisms. If we give them 60 milliliters over 3 sets, they have almost 100% chance of being able to capture the organisms that we are looking for. So incredibly important that we get the right amount of blood into those blood culture bottles. If we get too much blood in those blood culture bottles, what can happen is that the cells in them, the living cells that we've gathered in there, the blood cells, are metabolizing and they're giving off CO2 as a part of that metabolic process. CO2, as you know, is an acid, and so it can cause the color change, telling us that there's growth in that bottle. And they'll pull it out, they'll do all the gram stain and microscopic analysis, and they'll look at subculturing and antibiotic sensitivity testing and doing all of this unnecessary work just simply because we put too much blood. So the Goldilocks principle, not too little, not too much, just the right amount. And then when we're looking at contamination, the identity of the organism is the single most important factor that we look at. We're looking for common commensal organisms. And probably in your association, your hospital, you're seeing coag-negative staph as your most common contaminator if you're like everybody else in the United States. But that tends to be by far and away the most common contaminator. It's just so prevalent on our skin. But we can also pick up these other things: Cutibacterium, Aerococcus, Micrococcus, Bacillus, I always think somebody's fingertips got on something. Carinii, that's kind of a tricky one. We can miss this, a true bacteremia with this, because we don't get enough blood culture volume into those bottles, because Carinii tends to be in low volume. Sometimes we're only getting 1 colony forming unit in 8 to 10 milliliters. So be super careful with that. There's a great article on it. And when I'm talking about things, just know that it's coming from literature. And if you would like any specific literature, I'm happy to send that to you as well. So again, our contaminators, we're usually looking at this group. With our non-common contaminators, or non-common commensals, these are typically always going to be called a pathogenic organism, right? And they're not going to be called a blood culture contamination if we pick up any of the non-common commensals. And yet we know that we can have fecal patina, we can treat a patient systemically for Pseudomonas aeruginosa, and yet we can bathe them down with CHG, and that we can still culture their skin 24 hours later, and we can still grow out P. aeruginosa. It's crazy, the repopulation on our skin of these organisms. So again, the importance of getting our blood cultures right and making sure that we're not going to pick up any organism on the skin, be it a pathogenic organism or a common commensal organism. These group of organisms are typically the ones that are causing our false positive CLABSIs. And we're having to report these CLABSIs because it's not known as a blood culture contamination. It's known as a true bacteremia or fungemia. And these are typically the ones we're picking up on those patients when we're looking at the patient and thinking they do not have an infectious process. And we have a whole different lecture and CE on that if you're interested in that, but it's the false positive CLABSIs, false positive MRSAs that we're really learning to identify and mitigate. But when we look again at our common commensal pathogens, as you know better than anybody else, they can be, a common commensal can be pathogenic, right, as in these studies. And as we see with coag-negative staph as well. And then our pathogenics, if they're on the skin, they can be a contaminator, right, which you see in these studies. But the importance of this statement, given these data, clinicians attempting to differentiate true infections from simply contaminated blood cultures cannot rely solely on the identity of the organism. So we're looking at the patient's history, we're looking at their vital signs, we're looking at the rest of their labs, we're looking at all the rest of the clinical presentation of this patient to try and figure out what is going on. So polling question. Your hospital's definition of a contaminated blood culture is A, any common commensal, normal organisms found on body surfaces that grow in one set out of two sets drawn. B, any non-common or pathogenic non-common commensal organism that grows in one set. Or C, you're not sure. If Kelsey, you want to tell me the answer on that? That would be great.
Sure. So responses are trickling in. So far, most all of them are A.
Awesome. You guys are an awesome group. Appreciate you. Thank you. And then we want to kind of flip now and look at sepsis. And as you know, sepsis is the #1 cause of death, readmissions, and costs in U.S. hospitals. And our blood cultures remain that gold standard for being able to tell what organism is growing within their bloodstream, if anything is growing. And previously, and unfortunately, test results for sepsis were frequently wrong. And we had a standard that said a 3% contamination rate was acceptable. And the issue with that is that we take about 60 million blood cultures across the United States each year. That is a whopping number of blood cultures. And if we said that the 3% was acceptable, when we understand that only 8% of the blood cultures that we take out of that 60 million grow out anything at all. So if you put 3/8 as a fraction, you're going to have a 38% false positive rate that was acceptable. But if I said to you, every time you took a pregnancy test and it was positive, it was okay for it to be false positive 38 to 40% of the time, would that be okay? That would be total nonsense, and we would have all been up in arms about it. But here we've been doing this for decades with blood cultures, and it was because we really didn't have any other answers other than training and education. And we would keep our eyes on people, they do better, we take our eyes off, and it all hits the fan again. So now we know that false positive blood cultures are a preventable error, and it does lead to a misdiagnosis of sepsis. Chris Doran said that blood cultures are one of the worst tests in microbiology. Very encouraging, huh? And we know that false positive cultures are common, and obviously the effect and that's harmful on our patients are many. Because of that 40% of false positive blood cultures, we have a misdiagnosed patient. And with that patient, then we give them unnecessary antibiotics, and then that can lead to antibiotic resistance. It can lead to the risk of them getting C. diff, and we'll look at that more in just a second. But it also can lead to acute kidney injury. I don't know what your go-to antibiotics are, but across the United States, they tend to be vancomycin, which are great for killing organisms. But they also have a very negative synergistic effect on our kidneys, right? They are not nice to our kidneys, and we can have up to a 36% chance of acute kidney injury when we're giving vancomycin together to rule out with a rule out sepsis patient. And then obviously also we keep that patient an extended length of stay. The average time for that with contaminated culture and the average stat on it is we keep the 65% of those patients in the hospital for an extra 2 to 2.5 days. And then we expose them to HAIs and hacks. This is your worst nightmare patient, right? They're not supposed to be there. They're there, they pick up an HAI or hack. And then again, we can talk in depth about false positive CLABSIs, but know that that's picking up typically those pathogenic organisms on the skin during a blood culture, and we'll have to report those. And then we're also increasing the mortality of our patient by keeping them in the hospital and giving them antibiotics. One thing I did want to just add to the slide deck that you already have is a statement from the CDC. They said that with our hemodialysis patients, they have 100 times more likely incidence of having a Staph aureus bloodstream infection than our non-dialysis patients. That was horrific to me. And then the University of Arkansas study that came out just last year in 2022, they went back and did this massive retrospective analysis from their ED about all of their patients with blood cultures and the results. And they found a significant near doubling of inpatient mortality for patients when they had contaminated blood cultures versus a true negative blood culture in the control group. And that's when they threw out comorbidities and really narrowed it down. They still found an almost doubling for our patients when we contaminate those cultures, because we're keeping them in the hospital, we're giving them antibiotics, and we're actually decreasing their immune capacity by giving them antibiotics, and we're exposing them to more virulent organisms. And we know the effects of blood culture contamination. Over 1.4 million patients are affected annually by this. We spend $6 billion of unnecessary healthcare on these patients. We do have 3 million antibiotic-resistant and C. diff infections every year, of which we lose 48,000 people is the CDC's number, and they say they will tell you that that is a very conservative number. And then we know that we have a 20% chance of any patient receiving antibiotics of having an adverse drug event. So we want to get the test right. And when we look at what can happen when we do get it right, it affects a lot of outcomes, right? We can significantly reduce unnecessary and inappropriate antibiotic treatment when we get the blood culture right. We're driving antimicrobial stewardship. We're reducing the risk of C. diff, MDROs, AKIs, and other antibiotic-related complications. We're reducing false positive CLABSIs and CMS and NHSN reporting, right? We're conserving our laboratory, pharmacy, and human error resources. And then for the ED, we're increasing bed availability and throughput because these are not occupying beds that could otherwise be used for other patients. So the challenge and the solution is this. We have done incredibly important training and education, and we need to continue that on evidence-based practices, but that alone will not solve our problem. So we can control so much of it, right? We have to have aseptic, no-touch technique throughout, and we'll look at the specifics of that. But previously, what we could not control was the living organisms deep in the skin keratin layer, right before the blood vessel. Even if we wash our patient down and scrub them as in a pre-op scrub, and these are two studies that I'm going to quote here, they did the best possible pre-op scrub, and then they biopsied those layers of the skin and they cultured them out. And what we found is that 20% of our normal skin flora stay very, very alive in that deep keratin layer. And so when we take a hollow bore needle to get a blood culture, we have to go through all of those layers of the skin, right, to get to the blood vessel. And think about it with our difficult venous access patients. We're not coming all the way out of the skin. We're making tiny little micro movements in those deep layers right before the blood vessel, trying to really find that vein. And I firmly believe that is why our DIVA patients have a much higher incidence of blood culture contamination. But we're picking up those organisms or a piece of skin where they're present on, and then those are transferring into the blood culture bottle, and then we're growing out a contaminated blood culture. But what has been proven scientifically in now 9 peer-reviewed published journal articles is that if we actively divert more than the milliliter of a first aliquot of blood using a closed system initial specimen diversion devices, that has now been proven to reduce blood culture contamination. And I love this article from British Medical Journal. They looked at sustaining improvement measures, and what they found is that education and training, rules and policies, all of it ranks way low to when we force functions or we engineer a solution. And that's just human factors engineering, right? When we give an engineered approach, we know that we can get the same sustainable, desirable results. So polling question for you, your hospital's blood culture contamination rate ranges from 0.5 to 1.5, B is 2 to 3%, C is over 3%, or D is I'm not sure, which is a great answer because then you'll probably find out what it is. So A, B, C, or D, and then Kelsey, if you don't mind.
Yeah, so this one looks like much more of a mixed bag, Tammy. Lots of B's and C's, but we do have some A's and some D's as well.
Okay, great. And if you're not sure, please do find out what your blood culture contaminant is. And sometimes it's not a hospital-wide problem for the blood culture contamination rate. Sometimes it's an ED problem because for those poor ED nurses, like it's trying to do ICU nursing in the middle of a hurricane, or not a hurricane, but a typhoon, right? It is craziness in the ED, and their patients haven't been washed down, you know, with CHG 3 times. They get some tough scenarios in there. And usually it's a very much more difficult stick because sometimes their patients are crashing too. So sometimes it's an ED problem, but when we talk about false positive CLABSI, false positive MRSA, CDI, that tends to be more of a hospital-wide problem. So one of the first studies that were done on initial specimen diversion devices came out of the University of Nebraska. Mark Rupp, who you may well know from infectious diseases, his rate was below a 3%, which then was the acceptable average, right? It was 2.6, but he realized how many blood cultures he did, and he was very concerned about the outcomes for those patients because of the unnecessary antibiotics and hospitalization for those patients. And so he set up a study that was very, very highly controlled. And he took his same 12 phlebotomists during a 12-month period, and the first stick that the phlebotomist would do was with evidence-based technique and practices. And then the same phlebotomist in the same patient on the contralateral arm, they would do evidence-based technique, all the cleaning, bottle top cleaning, everything they're supposed to do, plus they use the initial specimen diversion device. And you can see the change there, right? And so what we see here is the Hawthorne effect, right? So my eyeballs are on you. We all drive differently with a cop behind us. They got a much better rate with training and education and evidence-based practices. But when the same phlebotomist with the same patient combined evidence-based technique with an evidence-based technology, they got down to 0.2% blood culture contamination and sustained it for 12 months over 1,800 blood cultures, 904 patients. And the great news was there was no change in true bacteremia either. So really what we should have been catching, we were still catching. That means that they had a 97% positive predictive value, so that when they did go coag-negative staph growing out, everybody could bet their bottom dollar that this was a true bacteremia with coag-negative staph and we were treating appropriately. If they had used this on every blood culture that they had done, they would have saved $1.8 million a year. So great study. And so I wanted to talk about how really then should we be drawing blood cultures. And it starts with patient selection. We should have a reasonable likelihood that we do have a bacteremia or fungemia in place before we start drawing blood cultures. But I would also say you should have no reluctance to draw blood cultures when there is that reasonable likelihood or expectation, because we know we can get these answers right now. Of course, skin disinfection is paramount. Use your CHG and alcohol. Scrub for your recommended time, dry from your recommended time per your manufacturer. And your bottle tops, scrub them with alcohol for 15 seconds. That was the Kaler-Chin study, right? It told us how long it took to kill organisms on an inorganic surface. 15-second scrub. And then either lay a new IPA pad on top of that blood culture bottle top. And if you don't want to do that, because some people are afraid the alcohol will go through into the bottle, then lay a sterile 1x1 on top of that. Protect it from the environmental contaminants. You've made that blood culture bottle top clean, keep it clean, because everything is flying around in that room and you know that better than anybody else. Phlebotomy sites. Obviously, we don't want to be drawing through indwelling vascular catheters unless the catheters thought through the source of infection. And in that case, INS asks us to remove the needleless connector, discard that needleless connector, and then draw from each lumen. Draw a second set from a peripheral venipuncture, And then consider time to positivity. I'm ancient, so we used to do these all the time, but they have an 80% positive predictive value. If you stick both the peripheral draw and the line draw in the incubator at the same time, and the line draw pops positive 2 hours before the peripheral stick, then you have an 80% chance that that is the source of your infection. And of course, we're going to send to that lab and not refrigerate the sample of blood. And then from INS also, they always want us to draw 2 sets from 2 different sites. And of course, these are adults we're talking about. And then always drawing blood cultures first, right? If we draw a lactic acid first and then we draw the blood culture, you're going to contaminate the blood culture top. Always draw those blood cultures first. Volume, we beat into the ground. Kits help. Phlebotomy teams help. Surveillance and feedback helps, and multidisciplinary teams. Everything is helped by a multidisciplinary team. But what happened is we kept going around in this crazy circle of evidence-based techniques, and we would keep our eyes on people, they do better, we take our eyes off, and again, our rates go up. It really wasn't until we combined evidence-based practices with initial specimen diversion devices that take away that last error possibility for us within the skin contaminants. These take a mil or more of that initial aliquota blood, so that what grows out in your blood culture was only from the patient's bloodstream, not from the patient's skin. Again, proven out in 9 different peer-reviewed and published journals, from Clinical Infectious Diseases, Journal of Emergency Nursing, Clinical Micro, ATIC, that's your magazine there, Journal of Hospital Infection. All kinds of amazing different specialties in nursing and medicine have told us that combining evidence-based technique and initial specimen diversion devices that take a mil or more, you will get amazing outcomes for your patients. This was just published in the last, and I haven't seen it, I didn't see it in the January issue, but it should be in February. What Dr. Tompkins did, she has her MD in infectious diseases, internal medicine, and then her PhD in microbiology. And she is a head of infection prevention at Stanford and also a professor there in infectious diseases. But she was very reticent to be giving antibiotics to people where she believed that there was a false positive CLABSI or a false positive MRSA. And the reason for doing the study was not so much for their contamination rate in their blood cultures, because they had, starting before, less than 2%. During the study, they had a 2.3%. But during the study at Stanford, they were able to completely mitigate blood culture contamination over 11,200 blood cultures, which we all thought was impossible, which is amazing. But it was done. And I thought there'd be a transient bacteremia somewhere, not one. 11,200 blood cultures, not one contamination. And then what they found when they looked at their false positive CLABSIs is that when they used the initial specimen diversion device, they had one bottle grow out VRE, and they weren't sure due to the phlebotomist documentation whether it was with the ISDD draw or it was standard method. And because it's peer review, the ISDD takes the hit. But when they didn't use the ISDD, they had 12. So their SIR fell by 30 to 50%. So imagine if you could get rid of 30 to 50% of your CLABSIs because you were mitigating all the false positives by picking up typically the pathogenic organisms on the skin. So great study there by Stanford. This one was done over a 4-hospital system, and the reason I show this to you is because 86% of these draws were done after the IV start. So they started an IV and they did the blood culture draw off of the fresh IV start, and there was no difference in their rates, whether they did a peripheral stick or off of a fresh IV draw. But amazing accomplishments over 4 hospitals. Their average aggregate rate was 3.5% blood culture contamination rate to start, and they went down to 0.6% using ISDD. And then this one I love with BAMC. Everybody and anybody draws in the emergency room of a military hospital, right? Everybody's taught how to draw blood. So they had a 6% rate, and they have a lot of turnover. And the standardization brought them down to 0.7% with ISDD, 90% reduction. The second arm of this study was to look at their vancomycin utilization. What happened? So first they brought in PCR. When they brought in Verigene, and that gave them an 18% reduction in vancomycin days of therapy hospital-wide. Months later, they brought in ISDD, initial specimen diversion device, into the emergency department. They got that huge reduction in blood culture contamination, and that parlayed into a 31% reduction of vancomycin days of therapy hospital-wide. So amazing outcomes for our patients there and for the utilization. 20 different studies. If you see an IV bag, that means that they use IV Fresh Start blood cultures. If you see a STAR, it means it's been in a peer-reviewed published journal. But really what I want you to see is the standardized decreases and the rates that were outcomes. And then the percent reductions. And so in medicine, we typically look for a 30% reduction as a great accomplishment. There's nothing in any one of these studies that is under 75% reduction. So amazing news for our patients. And so this group of key thought leaders really started studying all the literature that was coming out from amazing hospitals like yourselves that had taken the product in, done a study, published it, and they started to think, maybe a 3% standard isn't so good for our patients anymore when we know that we can do much better. So there was a call to action, and they wrote an article in Clinical Microbiology Reviews calling for a new standard of care for our patients. And then CLSI followed up with that too, and they said that we can do substantially better than 3% when best practices are followed. We should now have a target that is achievable of 1%. ENA, INS, CDC in July, and CLSI all told us that we should be diverting the first aliquot of blood, a mil or more. CDC said you should have a goal of 1% and use a diversion volume of 1 mil or more. So amazing status for our patients now, knowing that they have a new standard that will give them antimicrobial stewardship and quality outcomes that we look for. And CDC put this here, and it was one of the happiest days of my life because I felt like this burden was lifted off of me. And I didn't share with you why I joined this company, but I saw some of their early data. And I swore that I was going to be retired. I was not going to do 80-hour weeks anymore. I was done with it. But I saw their data, just very raw data, not peer-reviewed, not published yet, but it was very impactful. And I had just lost my dear friend and neighbor from vancomycin resistance. He was a hemodialysis patient, and he carried MRSA on his skin. Every time he popped a fever, they took a blood culture, and almost every time they picked up MRSA, and every time they treated him. And he died probably 15 to 20 years before he should have because of vancomycin resistance. And so I knew that for our patients, we really had to accomplish this. And I am so thankful for all of you in all of your hospitals that take on these new standards of care and these new evidence-based practices and make it so much better for our patients. But CDC really was hallmark in this, right? And very prescriptive in saying, there's really 8 steps to taking a blood culture correctly. And number 8 is initial specimen diversion devices, the devices that take 1 to 2 milliliters of blood so that we can get accurate results. This measure by CDC was submitted and developed and submitted to NQF, and NQF just formally endorsed it of December of this year. And then beyond that, don't shoot the messenger here, but we expect Hub or Hobsy to launch in early spring. I think maybe summer will be starting voluntary reporting. But the purpose of this from the government's perspective is that it's a much broader surveillance for bloodstream infection, right? Not just tied to one organism, MRSA, or the association with the device, i.e. CLABSI. But day 3 or day 4, they want to know what is hospital onset bloodstream infection. And NQF did just endorse this, I think last month. But the reason that they want to take a serious look at this is because it's serious nature for our patients. A 24% patient mortality compared to patients without a hospital onset bacteremia or bloodstream infection, much longer lengths of stay, much higher costs, and they believe it's common and preventable, up to 115,000 cases that currently aren't being reported. So with all of that, what if one practice change actually could, if we could just get this right when we're taking a blood culture, right? We could reduce unnecessary antibiotic and prolonged antibiotics, right? We can reduce C. diff, MDROs, and AKIs, reduce false positive CLABSI and MRSA, reduce unnecessary lab ID event reporting, reduce HAIs and HAGs, reduce inpatient mortality from the University of Arkansas study, meet the Joint Commission 703, I think it's 04, of reducing resistant organisms within your institution, their national patient safety goal. If you're a magnet hospital, this can meet your magnet requirements for a quality improvement. But a lot of good can come out of this, obviously. And I think most importantly for our reduced staffing capabilities, know that it's reducing laboratory and nursing labor. And then obviously it opens up beds for patients that really need to be there. Multiple studies have shown, especially the one from Journal Hospital Infection, have shown that if you're a 250 to 400 bed hospital, you could save $1.9 million annually, not inclusive of the mitigation of false positive CLABSI, false positive MRSA, and CDI cases. So really reducing blood culture contamination when we're taking this culture can do so much for our hospitals and patients. That applause, very obnoxious applause, is to wake you up and to tell you thank you. Thank you for correctly diagnosing your patients and mitigating all of these untoward downstream effects for them. And I do want to show you now the QR code. So if you'll take your phone out and just take a photo of this, that will take you to a document where you just fill out your name, the fact that you're an RN, and your email address where you want your certificate to be sent to. That would be awesome. And we'll just freeze on this for a good 30 seconds till you all have a chance to do that. Okay, anybody still, if you can let me know in the chat if you're still working on it, that would be great. And Kelsey, if you can let me know if anybody needs it out.
Sure. Not seeing any comments yet. Oh, a few more minutes, please. Right. If we can just go back one. That's okay, I spoke too soon.
I think we're all set.
Yep, I think so, Tammy. We can move forward.
Good. So I wanted to give you my contact information. This is my email. This is my cell phone number. I am more than honored to be able to send you any peer-reviewed article, any information that I can help you with. I have a library of about 150 articles on blood culture contamination, false positive CLABSI articles from AGIC, whatever it is that I can help you with, it's my honor to do so. So please don't hesitate to reach out to me at any time. And with that, I'll turn that back over to you, Kelsey. Thank you.
Awesome. Thank you so much, Tammy, for a wonderful presentation. You really covered a lot of ground in a very short amount of time, but I'm hopeful that this was helpful for our audience. I see a couple questions in chat. The first is related to sharing slides. We will have these slides available. They will be posted on the APIC Great Lakes website, and we will send a follow-up email after this session with a link, so you'll be taken right there and you'll be able to see them. Tammy, there was a question for you if folks can use the slides from today to do education for their staff on blood culture contamination.
100%. Whatever we can do to make it better for your lives and for your patients' lives, we're happy to provide that. But I really think it's important to get all the steps right. And I'm in the middle of writing an article and really doing a comprehensive steps based on peer-reviewed literature, literally over 100 articles of really what are the concise, steps 1 through 10 that we need to do. And the sheet that I showed you today on it is pretty inclusive, but there's a couple more things in there, like, use aseptic no-touch technique throughout the entire process. Make sure that the bottle tops are kept clean. Make sure that we're getting to the lab in a timely manner. Like, there's a lot of little steps in there, and I hope to have that be published fairly soon. But that will not only include that, but it will include in the appendix, that article, all the steps and then all of the peer-reviewed literature of why we ask you to do that step. But whatever we can do to help you, we're happy to do so.
Wonderful. Thank you so much, Tammy. I want to just back up. There was a question about the CE link. There was an individual saying that their security system was blocking it. I don't know if you have like a web link URL.
If you will, there's a link right here. So if you're online and you can access that link, would that not work either?
Yeah, so let us know, Sharon, if that works for you. If not, I'm happy to connect with you offline and we'll get that sorted.
Yes, and it's by Goodman Associates, and Terry Goodman is very, very, very good. If there's any problems, just reach out to her. And let's see.
And I see Eileen just put the link in chat, so that should work. Eileen, thank you for doing that. So you should just be able to click on that and enter the information. But yes, let us know if you continue to have problems and we'll work to get that resolved. Tammy, there was an additional question. Do we know when the blood culture contamination rate may go down from 3% to 1%?
Yeah, and according to CLSI, that's what they asked for last year, is that should be, you know, when we're doing everything right, that should be our goal, and it is achievable to when we're doing all these steps right. I don't know when NQF, they formally adopted the CDC's blood culture measure. The CDC's blood culture measure told us that we should have a 1% goal. What is going to happen with that in the future, we don't know. But that's up to CMS and CDC. But they're reviewing it now, right, to say, when do we enact this? And then, of course, HOB is coming along, too. So I know the government doesn't like to throw everything all one, especially post-pandemic.
I appreciate your insight on that. Hopefully that was helpful. Other questions for Tammy?
Yeah, and just realize that CLSI is kind of like the Bible for collecting blood cultures, and they're already asking that, and for NQF, it's already asking for that as well. So, and CDC's asked for it as of July. So my understanding is that it's already an expectation, is that should be our new goal, is the 1%.
And Tammy, just a lot of really positive comments in the chat. Thank you so much for an excellent presentation. And I would certainly echo those comments on behalf of the entire APIC Great Lakes board. I think this has really been enlightening and given us some helpful things to think about. There is a comment. Oh, I'm sorry.
No, whatever we can do to help, we're happy to. So go ahead. I'm sorry, there's a question.
No, there was a question / comment about the cost of the diversion devices, and this individual saying that that was cost prohibitive for them to implement, and just wondering if there will be any cost or price reduction on these in the future, or kind of, you know, what are you seeing, or what do you anticipate may happen?
Yeah, and I have a business degree, but I stay 100% away from the business side of it, because I really believe in the clinical, but I understand that economics are really important. So if you look at 9 different studies, the cost of a contamination, which, you know, have nothing to do with our company, the cost of contamination is around $4,000, and that's just the cost of the blood culture contamination. And so you would need to look at your rate and multiply that out, right? How many patients are getting misdiagnosed, and what's the cost? And then that, of course, is agnostic. That $4,000 is agnostic to the fact that, you know, we have 3 AJIC articles that tell us that between 30 to 42% of all the CLABSIs that we report are false positive CLABSIs, because we're picking up, typically, we can pick up the common commensals, but it's harder, right? And getting these false positive CLABSI and false positive MRSA. So if you start counting that cost in, the cost of any causation of C. diff, right? The cost of MRSA, and, you know, God forbid that the patient with the central line, they pick up a MRSA on the skin, because now you have a lab ID event and a false positive CLABSI. I mean, it just starts, you would have to calculate what that cost is, right? And so when you just look at blood culture contamination cost, the 200-bed hospital typically saves around $2 million. just when you look at the blood culture contamination cost, not inclusive of any CDI, false positive Class C, false positive MRSA. And we really don't know and aren't able to calculate that cost for you because we don't know your rates. So it's just something to consider when you're looking at the cost of the device. And I, again, have nothing to do with the cost of the devices or selling them to you. But that's a great question for Mark Mackey is on today. He's the business director for the whole Michigan area and Great Lakes area. So it's a great question for him.
And we'll be sure, Tammy and Mark, to include your contact information in the follow-up email that goes out in the event that folks have additional questions. With just a minute left here, I do just want to quickly give some APIC Great Lakes updates before we close out. I did mention at the start that the event flyer is posted with all of our 2023 events. And so our next session will be March 28th at 1 p.m. And we'll be doing a review of enhanced barrier precautions in long-term care. In the follow-up email that I mentioned, we will also include a link to our YouTube channel where all the session recordings, including today's session, are posted, as well as the link for where Tammy's slides can be found. And then one final reminder, if you do have any open job postings, please send those our way and we will be happy to post those to our website so that you have better luck recruiting and we can sort of make that a communal space for all of our infection prevention job postings across the state. So with that, Tammy, I just want to thank you again so much for all of your knowledge today that you've shared with us. I think this was incredibly well received. The questions and the comments in chat have been fantastic. And again, we will be sure to share your contact information so folks can follow up with any additional questions.
Kelsey, thank you so much for having me, and thank you to each one of you truly for what you do. Again, please hang in there, please, please. We need our quality metrics to move forward, so thank you for what you do. Take care.
Thanks all.